Hello, welcome to this digital learning series on nuclear disassembly. I'm Jacqueline Beltz. Nuclear disassembly is a critical step of phacoemulsification. During this step, we aim to remove the nucleus of the crystalline lens whilst protecting the integrity of the capsular bag and corneal endothelium. Divide and conquer is often the first technique for nuclear disassembly learnt by surgeons. It remains many surgeons' preferred technique and is an important skill to master. The aim is to create a pair of cross grooves in the nucleus that are of adequate morphology to then crack the nucleus into 4 quadrants for removal. The instrumentation, machine settings and phacodynamics are very important for nuclear disassembly and will be discussed in detail in another module. Basically, moderate flow, low vacuum and moderate phaco power are utilised for creation of the cross grooves. In this module, I'll go through some important points in relation to nuclear disassembly by divide and conquer technique. In particular, sculpting, rotation, completion of the sculpt, cracking, quadrant removal, complications, advantages and disadvantages. In preparation for sculpting, the nucleus must be rotating freely. Any loose cortical material can be aspirated to provide a clear view of the endonucleus. On the first pass, stop before reaching the capsular rhexis edge. Deepen the trench by using shallow, smooth strokes. Bury the tip of the phaco probe by about 50%, avoiding complete occlusion. As with all instruments, movements of the phaco probe should pivot around the incision to maintain wound neutrality. Aspiration should not be excessive, just sufficient to clear the emulsified lens material. Irrigation should be initiated before the phaco probe enters the eye. It should remain active for as long as the probe is in the eye. The irrigation level should be sufficient to maintain the anterior chamber depth. Use of the continuous irrigation setting might be useful for beginners. The nucleus should not move during sculpting. If the nucleus starts to move, the probe should be moved more slowly or the ultrasound power increased or the depth of the pass decreased. The first pass should be within the edges of the capsular rhexis. Subsequent passes can be slightly longer but do not need to go all the way to the edge. The width should be slightly wider than the width of the phaco sleeve. Traditional teaching suggests 1.5 times. Any less and the sleeve can catch, leading to the nucleus being pushed around. Any more and it's easy to create a bowl that is difficult to disassemble. It's beneficial to have longer, narrower grooves when the nucleus is soft. The grooves should be oriented 90 degrees to each other to create quadrants of equal size. The depth of the grooves is the most important factor for achieving successful cracks. The trench must extend most of the way through the endonucleus to allow cracking. This is particularly important in soft nuclei. Failure to do this, particularly in the central zone, where the cataract is thickest, is probably the commonest error when learning phacoemulsification. It's rare to pass the phaco probe through the posterior capsule. Conversely, failure to make the groove deep enough is likely to lead to capsular and zonular problems because the difficulty with subsequent lens disassembly. The depth of the trench is most commonly assessed by the change in the red reflex, which gets progressively brighter as the trench is deepened. You can see that quite here in the simulated footage. It's also possible to use the width of the phaco tip as a guide. It's usually about 25% of the width of the cataractus lens. Because of the concavity of the posterior lens surface, the trench is made shallower peripherally. This is also judged by the red reflex. The walls of the groove should be vertical, i.e. not sloped, to facilitate effective cracking. With sloped walls, the instruments may push the nucleus down rather than facilitating a crack. When the first trench has been completed, the nucleus is rotated 90 degrees to make the second groove. The nucleus is rotated by placing a second instrument in the very bottom and the very end of the groove and applying a rotational force. The rotational force, or torque, is the product of the force applied and the distance of this force from the centre of the movement. The second instrument is therefore placed in the peripheral part of the groove. The phaco probe can be used to assist rotation at the other end of the groove when necessary. The second instrument is rotated between finger and thumb to produce the required angular rotation. Note that leverage required to create the desired torque also depends on the position of the second instrument. I prefer to put the paracentesis approximately 2 clock hours from the main incision. The crosshairs of the completed grooves are created by repeated rotation and grooving of the nucleus. Some surgeons rotate the nucleus through 180 degrees and complete the trench in the original axis before making the side grooves. Others may make each groove in order as they rotate, as shown here. Provided all parts of the trench are deep enough, the order in which the grooves are made is not critical. The nucleus is cracked with a spreading movement of 2 instruments resting in the bed of the groove. Usually the phaco probe and a second instrument are used. It's important to place the instruments as far out and as far down into the groove as possible. Spread the tips of the instruments smoothly. Allow time for the crack to propagate to the centre and all the way to the periphery. The most common reason for cracking to fail is inadequate depth of the groove. The second most common is inadequate positioning of the instruments. The side walls also need to be vertical. Once the quadrants are freely mobile, they can be individually engaged and removed. During quadrant removal, high vacuum is used. Avoid the iris and the capsule. Only phaco within the margins of the capsular axis, in the iris plane. Mobile lens fragments should be engaged and drawn into the area before high vacuum is used. The first fragment may require some control and manipulation to bring forward, away from the other fragments, particularly if the nucleus is dense. This control requires occlusion of the phaco aspiration port and high vacuum. A brief burst of phaco power will be required to gain occlusion so that high vacuum can build up. Once this has been achieved, no further phaco power is used, i.e. the foot pedal stays in position 2 as the fragment is pulled into the safe zone. Short bursts of phaco power combined with aspiration can then be used to remove the fragment. The second instrument should be used to manipulate the quadrants, feeding them into the aspiration port and even chopping them into smaller pieces if required. I prefer to leave the second instrument in the eye at all times. Place it between the nuclear piece and the posterior capsule, especially on aspiration of the last piece. Anterior chamber instability is highly unlikely as a result of the second instrument's presence, especially with good wound construction, modern fluidics and good instrument handling. Anterior capsular break can occur if the first pass is too long. Not performing the upslope sculpt beyond the midpoint of the lens can cause rupture of the posterior capsule. Not performing the downslope sculpt ahead of the midpoint can leave a thick posterior plate which prevents the crack from propagating evenly. Using insufficient power while sculpting can push the nucleus and cause zonular stress. Inability to crack the nucleus can result from the groove not being deep enough or because the forces are not applied correctly. Cracking may also be difficult if the instruments haven't been placed deep enough or far enough out in the groove. Zonular dialysis and nuclear drop may occur if excessive posteriorly directed force is applied while grooving or cracking. Not maintaining the cruciate shape of the grooves or making the grooves too wide can result in a large central crater that becomes difficult to disassemble. Divide and conquer is an easy and effective technique to master. With dedicated practice, this technique is helpful to reproducibly break the nucleus into manageable pieces for removal. Divide and conquer is particularly satisfying in dense cataracts. It can be difficult to divide a soft cataract into quadrants. For some other cases, divide and conquer may require longer phaco time and higher phaco energy than some well-executed chopping techniques. Divide and conquer has been shown to result in higher endothelial cell loss for moderate to very dense cataracts compared to phaco chop. It's important to note that this difference is small and that until you master phaco chop, your endothelial cell loss may well be better with divide and conquer. I recommend structuring your learning with the goal of mastering all techniques for nuclear disassembly so that you can eventually employ the most appropriate technique for each case. Until then, make sure to utilise your best technique for live cases, especially the ones with higher risk corneas.